Good morning, everyone. How are you? Thank you for joining us today. Going to talk a little bit of a topic of shared decision making in the EP world, in the world that we live in now with electrophysiology. Talk about how its role plays in device implants and in catheter ablation procedures and where we see it going in the future. So, thanks for joining us today. We're going to talk a little bit again about, sorry, the CMS mandate for shared decision making and kind of define the essential elements of what shared decision making means and the techniques of how it can be achieved and performed in the office or at home, how patients can be informed about that decision making process, and a little bit of heightened awareness about how shared decision making has actually become a requirement for certain procedural reimbursements for us here in the electrophysiology world. So first of all, just discussion about what national coverage determination means, or NCD. I think we've all been through the NCD before, where you may see new procedures come up, especially in the EP world, when it comes from Watchman devices, left atrial appendage occlusion devices, even TAVRs. When these devices or procedures first come out, there's no coverage decision for them. Evidence has to be gathered, appropriate patient profiles who would best benefit from that particular treatment or procedure needs to be defined. So national coverage decision, coverage determination decisions are made at some point, at which time they decide which patients will be best candidates for these procedures and when to be covered. And at times when things first come out, the services can be covered at discretion of different Medicare contractors locally, but over time it does get a mandated decision and a separate CPT code. So NCD has mandated that as a prerequisite for certain reimbursements of these certain key procedures, including Watchman, even defibrillators, that shared decision making has been incorporated into its approval. So I just want to lay that out and let everyone kind of, we're going to discuss a little bit about that as well. So what is shared decision making? So it is a patient and medical team process where all the stakeholders, and clearly the stakeholders primarily are the physicians and the patients, come together to use data, outcome data from trials, discussion of patient preferences, and discussion of risk and benefits to make a outcome-based decision of what the best process for pursuing medical care is for the patient. Again, what that procedure may be, whether it's device therapy or ablation therapy, or even something as simple as medication therapy like anticoagulation for atrial fibrillation. So it somewhat envisions a more equitable role of discussion between the patient and the physician or physician extenders, such as nurse practitioners and nurses as well, or physician assistants. Sorry, I'm having trouble with my slides here. Oh, there we go. Apologize for that. So what is shared decision making again? So it's been implemented already for certain arrhythmias, for the diagnosis and treatments that ensue from those arrhythmias. So from something as simple as starting anticoagulation for atrial fibrillation, there's something more involved, such as discussion of the defibrillator implant for patients. And again, it's been mandated again for certain procedures reimbursement. So it goes above and beyond what you consider the informed consent procedure, where patients really have more of a say and more of a discussion of the long-term outcomes and downstream effects of what treatment they decide to pursue, whether it be the downstream effects of getting a defibrillator, not just the implantation of it, or the downstream effects of anticoagulants, risk of bleeding, long-term side effect profiles. And it's really designed to advance the principle of patient autonomy. So patient clinicians come together and discuss these evidence-based recommendations, and they're based on patients' outcomes, preferences, their values, and risk to benefit profile. So it's a very tailored discussion that physicians and the physician team have with the patients, and try to incorporate their background, their values into their ultimate outcome decision. And how is it implemented? A lot of times via decision aids. So we're going to go through a little bit about how shared decision-making process is facilitated by these decision aids. So a little bit first about how the outcomes are measured. So we have to have some solid data on the outcomes of shared decision making, meaning is it fruitful? Did it have its intended effect? Patient satisfaction, and how that can be measured typically by surveys. There are surveys that's been put out, the SDM Q9 survey. It's a patient's self-reported impression of their involvement in the process. And these also have been altered to allow providers to report their self-reported impressions as well. And observers can do the same who watch the discussion at the encounter to decide how the outcome of that process of discussion went. And typically, again, decision aids are also judged based on their benefit in the patient's aiding of their decision and long-term outcomes. And again, long-term outcomes include the likability of the tool, decision aid tool, satisfaction with decision preferences, and ultimately the outcome and intent of the treatment. So a complicated list of things. So decision aids go above and beyond traditionally what we think about sitting there for informed consent, discussing a procedure, having the patient sign a consent. They're really designed to give a better quality to that patient-provider communication to help tailor it to the patient's goals and values. So it goes through the medical discussion process typically about the condition the patient has, goes through the discussion of risk and benefits of the treatments, and promotes a more thorough clinical discussion between the patient and the physicians and physician extenders regarding either the procedure or the particular medical treatment that's being recommended for them. So again, decision aids, there are a myriad of different types of aids, and I'll show you some pictures, and at the end of the handout, the PowerPoint slide, I'm also going to provide a list of websites where some of these aids can be found. Traditionally, decision aids can include written handouts. They can even be websites and apps that patients can download on their phones or their iPads or whatever it is they have. It can be used either at the time of the official consultation or follow-up visits, or even patients can go home and they can look at these apps and these websites and then come back to the office and discuss it further. There is a national quality forum that was organized in 2016 to be somewhat of a certifier of shared decision making, but unfortunately they've been somewhat limited in the amount of tools that's come out of this particular forum. So examples, some of the decision aids for defibrillator implants. I think we're all familiar, those who implant are a bit familiar with the Colorado forum there, University of Colorado for implantable defibrillators. There are other forums that are out there through ACC and CardioSmart as well for discussion of defibrillator implants, outcome measurements, and tailored discussion with the patients. They can take home and review it. For left atrial, LAAC is left atrial appendage occlusion devices. There's some very good decision aids through CardioSmart and the NICE form that can be gone through. We even have personalized forms we have through our hospital that we designed where we can go through with patients as well at the time of their discussion in the office to decide if they're a good candidate for occlusion devices of the appendage, and they can take it home and come back and discuss it further. Anticoagulation for atrial fibrillation. CardioSmart has some very good forms, and interestingly enough, this past month there was a nice article trial out, Enhance AF by Paul Wong out of Stanford, where they designed a website app. I think it's afibguide.com. It's actually pretty good. I've gone through it and probably will use it for my patients, afibguide.com, where they go through a website app also designed patient education resource where patients can go home, input in their particular characteristics, and answer some questions and go through discussion of what is best for them based on evidence-based data. And then they can come back and they're able to write down their questions and come back and talk to the physicians more or physician extenders regarding their decision. And what it's actually shown is that long-term patients are more satisfied with their decision about whether to start anticoagulation or not. So a little bit specifically about certain procedures. As far as defibrillator implants, again, CMS has mandated the use of shared decision-making aids for patients who are going to consider ICD implants. So that means that if it's not documented, reimbursement will not be provided. And if it is provided, they can go back and take the money back if they wanted, as it is a requirement for reimbursement for the physician and the institution. And this was shared back in 2017, believe it or not, it's a long time ago, as a Class 1 recommendation through our society, American Heart Association, and HRS. And again, it's meant to really highlight to these patients not just the risk and benefits of getting a defibrillator implant, but also tailored discussion with their healthcare provider about some of the downstream effects of getting a defibrillator. Risk of future infections, risk of generator malfunctions, lead fractures, recalls. We've all been involved, unfortunately, in lead recalls and device recalls. If you've been practicing long enough, you've seen plenty of them. So just to share a little bit about the verbiage from CMS and NCD, this is what they actually have written, word for word verbiage from their website. As far as a covered indication, they say for these patients identified, a formal shared decision-making encounter must occur between the patient and a physician or non-physician. It could be, again, a physician extender, any of the above, using an evidence-based decision tool on defibrillators or ICDs prior to the initial implant. And it can occur, again, at a separate visit, but it has to be documented and performed as part of the coverage determination for defibrillator implants. Same goes for cardiac resynchronization defibrillators, but even for cardiac resynchronization itself, it's also given a recommendation, given its complex nature and involvement of multiple leads, implantations. As far as pacemakers, it's a recommendation. It's not a requirement for reimbursement, but even back in 2018, it was recommended by the ACC and HRS as far as the guidelines that came out for bradycardia and pacemaker implantation. It was recommended to discuss the risk and benefits through a shared decision-making tool. And again, it becomes more important, as you can imagine nowadays. Everything's become much more sophisticated. There's been evolution in our pacemaker therapy. We're not talking so much for every patient, the traditional transvenous pacemakers. We now have leadless pacemakers. And in the future, we may have multiple chambered leadless pacemakers. So all these complex decision-making that need to go into discussion with the patient, whether they're a better candidate for leaded devices, or even post-TAVR. As you can imagine, it's a very complicated discussion and becomes uniquely important to make at the time of implant or prior to implant if possible. For AFib and anticoagulation, I did go through recently that one trial again with the HANCE-AF discussion of shared decision-making and how long-term patient goals and decision, they're much happier with their decision long-term. And the issue really being that it is estimated about 50% of patients will stop anticoagulation after 1 year. And the discussion as to why this is and the research is really a question is how well was the education about the necessity of anticoagulation performed at the initial discussion? And that may be part of on the onus of the physicians as well. Our ability in that time frame of discussion in the office to really get to the patient about how important it is to reduce their risk of future stroke can be limited. So these shared decision-making tools really can help us. Patients can go home, review these websites, apps, handouts, come back and be more educated about their risk to benefit ratio and what best fits them to improve adherence and long-term outcomes for them, reduce the future risk of stroke. So we really want to engage these patients, improve the communication and discussion with them. And again, it was recommended in 2014, believe it or not, guidelines. It was recommended shared decision-making be performed. More of an individualized discussion. As you can imagine, that is a very individualized discussion. No two patients with AFib are alike. Their risk factors for stroke, their risk factors for bleeding, everything really varies. So it's a very intricate discussion. And then lastly, a little bit about the left atrial appendage closure devices such as Watchman. So CMS does mandate that shared decision-making be performed, documented in the chart as part of its coverage decision in the catheter-based procedure realm. And there are many different forms that can be used and decision aids that are out there. Some institutions, again, tailor their own decision aids to allow patients these reading materials regarding the best outcome, best options. Again, is it going to be anticoagulation? If they want to have a Watchman or they're a candidate for Watchman, why are they a best candidate as opposed to blood thinners or none at all? So in the 2019 AFib management guidelines, left atrial appendage occlusion device was a class 2B, but clearly is going to be improved above and beyond that in the future. So for ablations as well, in 2019, our consensus statement from ACC/AHA discussion of ventricular arrhythmias mentioned shared decision-making skills be developed. Nothing was mandated for ablations. But again, all these things you kind of piece together over time will likely become mandated. That's the thought, but definitely recommended, even for ablation, have that discussion. So how do we do it in a clinical, practical approach? Every institution is different, whether you're from a solo practitioner outside the hospital, or you're in a hospital-based institution, or in a large multi-specialty practice. Again, it starts at the physician side. Some institutions, again, have these multidisciplinary teams that come together, especially when it comes to structural heart and TAVRs, where you have the surgeons, the interventionalists, the general cardiologists. So typically physicians are the vector primary institution for initiation, at least of the shared decision making. And then these can be facilitated and taken over by nurse practitioners, physician assistants as well. It doesn't matter who, but it is a team approach that can be designed for every institution or every practice. And again, shared decision-making has clearly been mandated, required with the use of decision aids for reimbursement for not just the defibrillator implants since February of 2018, but again, left atrial occlusion devices since 2016. So this is nothing new. It's just becoming more discussed and more prominent about the needs and the requirements that are out there per CMS. So how can we help adopt this, and what can institutions do to facilitate their own adoption and to make sure that documentation is performed, not just also for their own reimbursement, but for the benefit of their patients? So again, a lot of times development of these physician extender programs where every institution has a team approach, a shared decision making, definitely makes it easier to institute. And there have been EMR systems that are trying to integrate these digital tools into the system so that it can be documented easier. We do that at Adventist. It's not as seamless as we want it to be, but it's an upload of one of the forms prior to implantation of defibrillator, so that it's documented that it's been performed before defibrillator implants. But these systematic approaches definitely can help larger institutions reach out to their patients and identify even site-specific champions that could help implement it. So the important part actually was talking about future directions. This is actually a good slide, again, to go over about facilitating adoption of shared decision-making. So again, using a team approach is vital. I know some institutions are doing that already. It's easier for certain procedures versus others, such as TAVRs, left atrial appendage devices. So we're really talking about involving physician extenders, having physician champions at different sites that can help implement these tools and decision aids to help not just for documentation, but for discussion of the shared decision making, and help to integrate it into our EMR systems. Most places now, outpatient offices, physicians, even obviously the hospitals, have sophisticated EMR systems, and they were developing digital tools that help implement and integrate those shared decision-making aids into the EMR. And this actually will be helpful for the patients and documentation for reimbursement as well in the future. So there's also been talk about developing better shared decision-making aids for family members and surrogates in situations where patients have cognitive impairment. As you can imagine, that is not as uncommon as it sounds. And there's also discussion about how to improve adherence and well, really adherence to shared decision making. And that may include ways to improve reimbursement. documented time spent by clinicians or clinician extenders to improve reimbursement. In the future, there may be some codes developed for that. There's discussion of that. And there's also discussion, again, that societies may come down and reinforce more solid recommendations for shared decision making in other procedures in the EP world, including pacemakers and ablations. And when they do, and if they do, more concrete pathways for implementation would be welcomed. That would help with adherence and actually make it easier for institutions and physicians to make this happen. So again, studies are out there already looking at shared decision making. I quoted one recent one by Paul Wong, the Enhance AF, where they looked at patient outcomes. So they're coming out slowly but surely, and that's going to help all of us in the future for sure. So at our institution, how we implement shared decision making, we have our own separate team approach for left atrial appendage devices, closure devices, and TAVRs. We use physician extenders, and registry team members to make sure every patient has that shared decision making discussion. Either the first office is with the patient and the physician, or with the physician extenders afterwards to make sure that they're comfortable, all the questions have been answered, and it's been documented and incorporated into the electronic medical record at the hospital. Same thing for defibrillators. It's less of a team approach at this point, more physician documentation. And we actually use the Colorado Decision Aid as a form that we typically complete prior to implant to scan into our EMR. Unfortunately, it's not automated where we can check it off, but it's scanned into the EMR that we use at our institution, which is Cerner. So again, shared decision making is here to stay. Trials coming out to definitely look at the risk to benefit, the cost effective nature, and definitely patient outcomes have been shown to be improved. Patient satisfaction is a primary outcome, definitely. And look for future mandates for shared decision making, as requirements for reimbursements are definitely likely on the horizon. And a little bit of some of the websites, definitely not all inclusive, just some of the CardioSmart websites, Colorado program, the NICE forms that can be used for discussion of defibrillators and anticoagulation and things of that nature.
My name is James Bobacek. I'm ACC's Director of Regulatory Affairs. Back when the ICD National Coverage Policy was updated a few years ago, I was one of the people who worked on that. But I think there's little I can add after Dr. Mofred so thoroughly went through the kind of the history of shared decision making and how it's been required by the agency in some instances. So I just had a few slides that are, I fear, rather redundant at this point since you covered everything so well. But I think the key thing that we were thinking at that time was looking for ways to, and the agency wanted it also, was looking for ways to make sure patients were fully engaged in their care decisions. And so, based on the guideline, I think I included a link to the 2017 guideline on management of patients with arrhythmias and avoiding sudden cardiac death. Was some of the language that drove the ACC and the Heart Rhythm Society to look at this in the final policy. You might also remember that was up to that point. Participation in a registry was a requirement of coverage through coverage with evidence development. Can I see the next slide, James? And so this is just I think you actually had this exact quote, Dr. Mofred. So this is from the ICD coverage policy. And on the next slide, I included links just for anyone who would desire that information. You could go ahead and advance, James. Just links straight to the coverage policies for ICD, NCD, and also the LAAC NCD. And then finally, James, if you can advance to the last slide, I had mentioned the registry collection. The data collection requirement that previously existed. So the EP device registry is not something that people must do as a condition of coverage for Medicare under coverage with evidence development, but it's still a really valuable tool for quality improvement and continuing to understand the services. And right here is highlighted the lines that talk about documenting the shared decision making in that data collection. So it remains a useful tool for that.
some questions that have come up for Dr. Mofert, so I will begin at the beginning. So how are you documenting the SDM tool in the medical record?
Sure. Um, uh, well, it's done when it comes to the two things that's mandated from CMS, at least for our practice in our hospital. Left atrial occlusion devices and defibrillators, we're actually documenting in our outpatient notes. And then for defibrillators, that tool, typically we use the Colorado tool. We upload a form at the time of implant into the EMR. We tag it with a patient identifier, so it gets scanned into the EMR on its own. So those are the techniques we're using. That has to be seen at the time implant by the physician extenders and the disciplinary team, that has been documented in the outpatient note by the clinician or the nurse practitioner that's involved in that patient's care. So if not, then of course the procedure doesn't go forward till it is. So it's not as seamless as we like, but documentation is important.
Great, thank you. Is there a time frame prior to implant that the tool should, quote unquote, be used within 1 year of implant? Any guidance on that?
I don't have a particular guidance. I think clearly, once you make that decision to proceed with the defibrillator, you usually don't wait a year, even for an appendage occlusion device. So I think really the discussion comes along when you're ready to proceed. I don't think there's a time frame. It's done as an outpatient, so it's a couple months, it's fine. There's no clear expiration, but again, when a patient qualifies for it and they want to move forward, it's done so. But I can envision if you wait 6 months for an implant, you've gone through, you've documented your decision aid used, there isn't going to be an expiration per se. So any time prior is fine.
Great. Should CSBP conduction system pacing, such as LBBAP and HIS, be included in SDM discussions? Are there any SDM tools that include CSP?
That's a great question. I think we're even looking, just to be honest with you, just for guidelines from our own institutions, hopefully coming out this year, regarding the appropriateness of conduction system pacing. We're actually looking for guidelines, looking for class 1 or class 2 indications coming out this year. So no, I don't have any shared decision-making tools designed particularly for that. But that's a discussion that I tailor in my office and actually document through templates in my notes, my electronic notes. And I think it's going to become more important in the next 1 or 2 years, because I do envision, and everyone agrees, that that conduction pacing, system pacing, is going to gain class 1 or 2 indication from our own ACC and HRS institutions. So I think until that happens, you're probably not going to see too many shared decision-making tools, but that's really up and coming next on the horizon, because it needs to be done. That's why when we talk about the the complicated nature of pacemaker implants and ICDs, why it's getting more complicated, because there's so many more choices and there's more data coming out, and we're learning a lot more about what may best benefit particular patient population. So it's a great question, but look for a lot more to come out soon for sure.
Great, thank you. Are there examples of reimbursement being refunded or withheld because SDM requirement was not satisfied?
Another good question. I don't see any in our institution. Again, I can envision it could happen. We definitely had it when there wasn't good documentation of the ICD tools that was shown earlier. But again, it's in the guidelines. So if they go through and CMS wants to look through some charts.
Great. Okay, so our next question is on, if possible, more clarification about what documentation for SDM is acceptable in the medical record would be helpful. We have a checklist, but there has been feedback from auditors that more specific documentation is needed, and they even suggested having a copy of the tool in the medical record, although that is not specified as required by NCD.
Yes, it's not specified, just specified that you did have that discussion and was performed. I actually have the tools. What I do, I keep in my office a list of the tools and different handouts for the patients, and I typically document which one was given to the patient. You're right, it's not really practical to upload an empty copy into the form. You're not having the patient necessarily sign the form. But I think you have to really discuss within your note would be beneficial is which tool you actually use. I think if you do that, then I think you're covered. If you say, listen, this form is given the patient, this particular shared decision-making tool was used and implemented, then I think that's really all you need to do. I think they're looking just more guidance of maybe particularly what form you use. And there are forms out there that are recommended. You're not flying blind. Some institutions definitely derive their own tools based on generic tools out there, and that may be something you include within your hospital-based institution or physician group. But I think at this point, it's practical to use forms that are out there and actually list within your note which tool you use. I think that's more than sufficient.
Great. Is there any merit in utilizing scoring systems for AFib patients, such as the CHA2DS2-VASc, for example, in aiding patients to coming to a decision?
Oh, 100%. 100,000%. I think when it comes down to atrial fibrillation and anticoagulation, again, very nice novel tool by Paul Wong, the afibguide.com, where it goes through and patients check off their risk factors and a thorough discussion of what a CHA2DS2-VASc score means. So patients actually understand why we recommend anticoagulation. So yes, 100%. I think documentation, discussion of it, and education of the patient of why they qualify for blood thinners is important, because that has implications if they don't tolerate blood thinners down the road and you want to discuss a left atrial appendage device, occlusion device, why even mentioning it? Patients don't always understand. We spit out all these numbers and acronyms of what it all means to them. I think it's important to have a thorough discussion, document it, so they understand, hey, listen, you're at an increased risk of stroke. So if you can't tolerate blood thinners down the road, an occlusion device is warranted, and documentation of that risk score is definitely important in your decision making as far as whether you're going to start them anticoagulation or not, or recommend a Watchman if their Hasbled score is high. So yeah, all that very important, very important.
Great. Will the existing tools, such as the University of Colorado version, satisfy the CMS requirement if all ICDs are not are not represented, such as TV versus SICD?
Yes, I think at this point it is. It is covered and it's reasonable. And again, just remember your note also augments that. So in your note, you're going to discuss that you've reviewed the options of transvenous versus a subcutaneous and why the patient decided after discussion with you a subcutaneous is more appropriate or more beneficial for them. So it's not all about the tool. It's also about what's documented in your note. So as long as you document discussion utilizing Colorado tool, the risk, the benefits of different options and why the patient went for that option, even one sentence is more than sufficient. There hasn't been anything that I've seen.
Are there any statistics on how frequently patients receive a device after having the SDM discussion, perhaps compared to pre-SDM requirement, for example, 2017 and earlier versus 2018 and later?
I'm not really sure. I mean, again, discussion, the risks, the benefits, all that's very important. But prior to that time, since it wasn't mandated, I don't know of any discussion comparatively looking at patient outcomes or satisfactions, comparing prior to more present day. I'm just not aware of that. I don't think anyone has. It'd be very difficult to do that, look through that and find hard endpoints to discuss, given that now it's become so seamless and so incorporated into how we approach the patient. I don't think you can even retrospectively find as much data prior to shared decision-making tools being used. I don't know. Sorry, I plead ignorance on that. I don't think so, no.
Okay, thank you. The Colorado SDM tool only addresses primary prevention. What do you use for conditions that are not covered with that tool? For example, HCM, high-risk LQT, etc.
Well, again, I think the implantation is important. Sure, it's for primary prevention, but that discussion tool is still recommended for any primary prevention implant. If it's secondary prevention, then again, all bets are off. The patient had a sudden cardiac arrest, you're implanting it for a reason. But if for any primary prevention necessity, that those Colorado tool or any other tool you use, what it tries to do is go through the risk and benefits of implant or show that you've gone through those risk and benefits and talked about some of the downstream negative effects and positive effects of having defibrillator implant. So again, I think it's not so much important to get caught up on what aid you're using. It's important to use that aid, but also your discussion and your patient chart and your documentation is vital. I always have a very thorough discussion in my documentation, initial visit and subsequent visits prior to implant, how I went through the risk and benefits of other options and why it's being recommended. So I think as long as you have that Colorado plan looked at for primary prevention or even secondary, and you go in your note and augment it, there should be no issues at all.
Great, thank you. So here's a question regarding the tool. Is it suffice to document the Colorado tool was utilized and provided the patient, or does it have to be scanned in the EMR?
It doesn't need to be scanned in at all. I think as long as you document that you provided shared decision making, and if you mentioned the tool, because someone has specifically asked before, they're having some issues, I think that's all you need to do. You do not have to scan it in. We typically scan in our tool for inpatients. Don't ask me why, but we've just kind of done that, but we actually discuss it and we use that form and have the patient sign it. But in our outpatient setting, we don't do that. We just mention which form we use and have that discussion and put it in our note. So no, I don't think it's important that anything above and beyond scanning that form in is required. No, just documentation of what you used is reasonable.
Okay, the Colorado tool only mentions transvenous ICDs, but does not mention the non-transvenous, the ICD, which does not have complications associated with transvenous leads. Should this be added?
Well, I think it'd be nice to add it, true. But like I said earlier, I just augment my discussion in the office where I mentioned that we discussed the importance of the defibrillators, the benefits, the risks, and then I augmented my note why the patient has opted for the transvenous, I'm sorry, for the subcutaneous, and the differing implant about how it's going to be different for them long term. There isn't a particular tool for subcutaneous. I don't think they're actually looking for that for reimbursement, to be honest with you. So I wouldn't be concerned at all about that. Again, you're discussing these things in the office of why they may be a better candidate for a subcutaneous device, and I think that's all that's necessary. You don't have to be worried about a lack of a tool for subcutaneous defibrillators being specifically presented in the record and quoted. Your discussion is sufficient.
To a formal shared decision-making interaction with an independent non-interventional provider that either has a relationship with the patient or those with experience caring for stroke patients using an evidence-based decision tool on oral anticoagulation in patients with NVAF prior to LAAC. They wanted more guidance for doing this with LAAO because they have providers that don't really have the understanding of a LAAO procedure, and the process isn't going
Yeah.
smoothly.
Well, I think that's the reason why, at certain institutions you have physician champions or physician extension champions identified. I think it's going to be important probably that with the knowledge, the base, and the experience at your institution, who will be the primary shared decision-making person, maybe not primary, but in a group of people. So I don't think it's beneficial, like you said, to have a person, individual, physician extender, physician who's not involved in the process or doesn't have experience to be doing it. I think that's not good for the patient. That's the purpose of shared decision making, to have that discussion with someone who has the knowledge. So I think it's probably easier answered as who can you identify at your institution as a champion.
A couple other questions just came in, so we'll just take these two.
Sure.
For LAAO, can the referring provider have the SDM conversation?
Oh, yes. Again, if the referring provider is a cardiologist, I think they can have the discussion, but the documentation should really be done with the person who implants or who's part of the team implanting. So anyone can have that discussion. It's important. But wherever you're located, LAO occlusion devices are quite, complicated. It's a team approach procedure. So no matter what, even if my referring cardiologists have that discussion, I'm still going to have my own and document it. So it never hurts to have it. But I think the bottom line is the team that is providing that care is still going to document it in their medical records. We have our referring cardiologists actually sign a form, and we sign our form. That discussion was made, so we both actually do it. So I think it's important. You're going to have probably both people. Yeah.
Great. So thank you, Dr. Mofred. We've had a number of
Thank you.
thank
That's
yous
all right.
come through on the chat. Thank you so much for attending.